Hi everybody, this is Jill Morgan and I'm talking about infectious pulmonary diseases and in particular lung abscess. This is part 3 of a 4-part series. We'll end with TB. Welcome to lung abscess. This is a picture of a lung abscess. You can see where the yellow arrow is pointing. It's a big, what we call cavitation, or a big hole in the lung surrounded by scar tissue and filled with infection. That's what a lung abscess is, a loculated infection inside the tissue of the lung. So what happens to the lung? Anatomic alterations of the lung include alveolar consolidation, alveolar capillary and bronchial wall destruction, tissue necrosis, basically rotting flesh, cavity formation, which you saw in the picture, fibrosis and calcification of the lung tissue or lung parenchyma, bronchopleural fistula and empyema, atelectasis, and excessive airway secretions with empyema. Common causes of aspiration pneumonia and lung abscess include alcohol abuse, seizure disorders, general anesthesia, head trauma, cerebral vascular accident or stroke, and swallowing disorders that are common in the elderly. Lung abscesses are most common as a complication of an aspiration pneumonia, and that's why you see these things causing a lung abscess. Anything that makes it you sleepy or have trouble thinking or swallowing. Some common organisms that are known to cause lung abscess, and I apologize in advance, I'm going to butcher these names, but anaerobic gram-positive cocci, they include peptococci and peptostreptococci. Common gram-negative bacilli include Bacteriorhides fragilis and Fusobacterium. Other less common organisms are Klebsiella, which leads to current jelly-type secretions. They look like someone just spit a bunch of jelly into your hand. Mycobacterium tuberculosis, Histoplasma capsulatum, Coccidiodimides, Immitis, Blastomyces, and Aspergillus. So these are less common, but still you do see them on occasion. There also are some parasites, and on rare occasions, things like Streptococcus pneumoniae, Pseudomonas aeruginosa, and Legionella disease all can cause a lung abscess. So what will you see at the bedside with someone with a lung abscess? Some of the clinical manifestations that you might see are alveolar consolidation on a chest x-ray with an increased density from consolidation and atelectasis, air bronchograms, lung abscess with an air and fluid-filled cavity, and possibly even empyema or pleural effusions. The radiographic signs vary considerably depending on the causative agent and the stage of the lung abscess. You will also see increased bronchial secretions. Clinical data obtained at the patient's bedside. What will you see at the patient's bedside? You will see increased vital signs, increased respiratory rate, heart rate, and blood pressure. You may also see chest pain and diminished chest expansion, as well as cyanosis, cough, sputum production, and some of that sputum may be bloody or hemoptysis. When you listen to the chest, you may hear crackles and rhonchi. You may also feel tactile and vocal fremitus. And directly over the abscess, there will be a dull percussion note, bronchial breath sounds, diminished breath sounds, whispered soliloquy, and there could be a pleural fiction rub if the abscess is near the pleural surface. On chest x-ray, you will see increased opacity, or it's wider. Cavity formation, so there's a big hole, and here's a picture of a lung with a hole. Cavities with air and fluid levels, fibrosis, calcification, and possibly even pleural effusion. Here is a picture of activation tuberculosis with a very large cavity lesion containing an air fluid level in the right lower lobe. There is a smaller cavity in other lobes, but here in the right lower lobe, you can actually see the level fluid in the round cavitation. Interesting, right? So as an RT, how do you manage lung abscess? Antibiotics are the primary treatment for a lung abscess. From the RT standpoint, you'll make sure that you follow oxygen therapy protocols, give oxygen when needed, use bronchopulmonary hygiene therapy, things like vibrating PEP and things to help them get rid of their secretions, and lung expansion therapy. So TheraPEP, an incentive spirometer. So to maintain the alveoli as puffed up and as sputum-free as possible. So, according to Stephen Covey, we are going to begin with the end in mind, and so you are going to be thinking about how you can help treat your patients when you're an RT.